whether it is male or female, the reproductive organ is divided into two parts. One is external genital organ and internal genital organ. External genital organ, what we can see, the different, we can have some idea about the different parts and their structures, and definitely the internal genital organ. Now first we will discuss the internal genital organ. The internal genital organ, here we can get, that is the uterus. So uterus, where we can see the embryo gradually develops into a mature fetus. This is the womb, the mother's womb, and this shape and size changes with respect to age and with respect to the whether nulliparous and whether it is a pregnant uterus, whether it is and whether it is beyond the menopause, there are some changes. Okay. So uterus remains within the pelvic organ, it remains within the true pelvis. So it is a pelvic organ. So it may change during its pregnancy. There is enlargement of the uterus. It will enter into the abdomen. So that will become abdominopelvic organ, and ultimately it will be the height of the fundus may reach up to the leafy sternum. During the term, it can reach up to the leafy sternum in the anterior, just behind the anterior abdominal wall. It can increase, and that is called the fundal height. The fundus of the uterus may reach up to this level. Now uterus has got three parts. One is the fundus. We will see the picture. Fundus, it's a muscular part and it is a solid area, and then we can get the body where we can get a cavity. Okay, and it is pear-shaped structure. The fundus is this part where we can get no cavity. Uterus has got different muscles. There is a myometrium, and it is covered with a peritoneum. It is called perimetrium, and the muscular part is called myometrium. And inside the lining or the lining of the uterus, here we can get, okay, that is called the endometrium. So from outside inwards, we can get peritoneal layer, that is the perimetrium, then myometrium, and inside is the endometrium. So within the body you can see there is a cavity which is called the uterine cavity, which communicates on either side with a tube. We can get, that is the uterine tube or the fallopian tube. And in the lower part, it is continuous with a canal which is called the cervical canal, or this part is called the cervix. So here it is continuous on either side with the fallopian tube or uterine tube, and here it is continuous with the cervix. And this area between the body and the cervix, this area is called the isthmus. Isthmus. So uterus has got this fundus, body and cervix. And you can find this cervix, a part of the cervix is within this area, which is called the vaginal canal. So we can find two parts of the cervix, which is one is within the vaginal canal, one is above the vaginal canal. This part is called the supravaginal part of the cervix and intravaginal part of the cervix. And the cervix it extends from this ostium to this ostium. The innermost ostium or opening, that is called internal os. This opening of the cervix towards the body, it is called the internal os. Whereas this opening within the vaginal canal, that is called external os. There are, again, the internal os has got two different names. One is anatomical and one is histological. We will learn gradually. So, fundus, body and the cervix. Okay. Now, it is a pelvic organ, but during pregnancy, it may reach the abdomen. It will reach, definitely. Not only it will reach the abdominal cavity. Now, total length, you can see from the fundus to the cervix, you can see it is around 3 inches. 3 inches. Whereas the cervix is around 1 inches. So the ratio between the uterus and the cervix is 2:1. Okay. But it is an adult one. In case of adult, it becomes 2:1. Okay. In early childhood period, it may remain 1:2. That uterus is 1 and cervix is 2, the ratio. And so that is the muscular part of the body. Okay. We have already come across with the cervix and this is the isthmus. That is the junction between the body and the cervix, that is the isthmus. And on either side, this opening, it looks like a horn. And that tube looks like a horn, that is a cornu. Okay, so it communicates with the uterine tube. Now about this is the cut section, what you are seeing. But in an intact uterus, you can find two surfaces. One is in front, one is behind. And the surface is not plane, rather it is convex. It is a convex surface. There is a peritoneal relation that already you know, that is the pouch of Douglas, you know, that is the rectovaginal pouch and uterovesical pouch. You know, this is the position of the uterus within the pelvic cavity. In front, we are getting the urinary bladder, which is continued as the urethra. This is the symphysis pubis. So, behind the symphysis pubis, we are first getting the urinary bladder and urethra. And this is the opening of the urethra, that is the external urethral orifice. And this is the uterus, and this is the vaginal canal. So, this uterus, what is the position of the uterus? It rests on the superior surface of the urinary bladder. And here we are getting the reflection of the green one is the peritoneal reflection. This is, we know this is the rectum. This peritoneum is reflected from the upper 2/3 and lower 1/3 of the rectum, and then it covers a part of the vaginal canal, posterior surface of the vaginal canal, and then it is reflected over the uterus, and it comes in front and it covers, and ultimately it is reflected from the isthmus. This is the isthmus, that means this is the junction between body and the cervix. From here it is reflected and we are getting, and then it covers the superior surface of the bladder and it comes in the abdomen. It covers the posterior surface of the anterior abdominal wall. So, we are getting two area. One is, this is the pouch of Douglas, that is recto-vaginal pouch. This is between the rectum and the vagina. So, recto-vaginal pouch of Douglas, and this is the between the uterus and the bladder. So, it is uterovesical pouch. And you know, this pouch is definitely dependent part. Here we can get the coils of ileum, okay, within it. And this is very important area because any fluid collection can happen here, and like any fluid which is coming from the abdomen, it's a dependent part, it gets settled down. And also during ectopic pregnancy, generally which happens within the uterine tube. So, when it ruptures, we get the blood, and there is a blood collection within this recto-uterine pouch, a recto-vaginal pouch, that is the pouch of Douglas. So, uterus has got anterior surface, which we can see, and another, it obeys the law of two. Posterior surface. There are two surfaces. One is anterior, one is posterior. Laws of two, that means it obeys a laws of two. Then it should have two borders. We can have two lateral borders. We can see there are two openings which opens within the uterine tube. Okay. So, there are two lateral borders. Now, here we can see, we know the gubernaculum. The gubernaculum is a fibromuscular structure, okay, and it connects, on one end it is connected to the ovary, and also it is connected to the processes vaginally, okay, or this is from ovary, it comes out and it traverses the inguinal canal, and it ultimately it is attached to the labia majora, because labia majora represents the genital swelling. In case of male, we know there is scrotum, so that whole gubernaculum from the testis, it comes out and ultimately it is attached to the scrotum. Okay. So, similarly, in case of female, this round ligament, it passes through the deep ring, you can see the inferior epigastric artery. This is the superior superficial ring. Ultimately, it is attached to the labia majora. Okay. Now, when it was dragging the ovary from the posterior abdominal wall, what happens? There is a simultaneous development of the uterus. So and this uterus intervenes between this ovary and and we are getting the genital swelling, that is the labia majora. So the journey is been restricted by the development of the uterus. Okay, and journey has to be restricted because the ovary will not move through the inguinal canal. So uterus becomes a barrier. Very good. Then what will happen? So this gubernaculum will have one proximal part and the distal part, and it is connected with the uterus also. So this part is, the proximal part is called the ligament of the ovary. Okay, the connection between the ovary and the uterus. And another connection, the distal part remains, and which is connected with the labia majora, that is called the round ligament of the uterus. Which this round ligament of the uterus, it acts as a tent. In the tent we have seen what, there are some ropes which helps to keep the tent in position. Okay, so there are two angulation I will show you. That is antiversion and antiflexion within the uterus, which is very much necessary, otherwise uterus will come down through the introitus. So these two ligaments on either side, it drags the uterus in front. Okay, so this is the distal part of the gubernaculum, which remains as a round ligament. Now, this is the angle what I was saying. There is an angle between the long axis of the uterus with the long axis of the vagina or vaginal canal. You can see the long axis, this is the long axis of the uterus and this is the long axis of the vagina. So we can get one angulation, that is 90 degree. This is called the angle is called the Varshan. Okay, Varshan. As uterus is normally it is directed in front, so it is called antiversion. The angle is called the Varshan, that is 90 degree. As it is the angulation is in front, it is called antiversion in normally. Okay, so that is 90 degree. And there is, we know this is the body and this is the cervix. So this is the junction between the body and the cervix. Okay, here we can get another angulation between the body. This is the isthmus, this is the body, this is the cervix. So we can get an angulation at the level of the isthmus in between the long axis of the uterus and the long axis of the cervix, and that angulation is around 125 degrees. That is called antiflexion. So uterus is not only directed in front, but there is an angulation within it, that is called antiflexion, that is flexed in front. So this is called antiflexion. Okay, so antiversion and antiflexion, these two things are necessary. Why? If the angulation is lost, what will happen? Uterus will become suppose this is the uterus and the angle is lost, okay, and the uterus becomes straight. What will happen? uterus will come through this vaginal canal, will come out through this vaginal canal. So there will be prolapse of the uterus. Okay. And you will know what are the factors which are keeping this angulation. Okay. So what is retroversion? Retroversion is just opposite. This angulation is in front. If the uterus is directed on behind, okay, that is called retroversion. Why these are important? These are important in the obstetrics. In the retroverted uterus, there are some obstetrical complications. Okay. And so, at least you should have one idea, that is the retroversion means that when this angulation is lost and the uterus is directed behind, that is the retroversion. And uterus may rotates on its own axis, either on the right side, on the left side. That is called dextrorotation or levorotation. Generally, the dextrorotation is common. So, you can see the relation of the body of the uterus. In front, we are getting the urinary bladder and symphysis pubis behind the rectum, and here we can get the coils of ileum. Here also we can get other structures. Here we can see the peritoneal covering on either side of the uterus. Like it covers the uterus and it is continued to the lateral pelvic wall. And this covering is called and becomes a peritoneal ligament, broad ligament. So that is called broad ligament. So this ligament is called the broad ligament. So laterally it is attached to the lateral pelvic wall and medially it is attached to the either border, this right or left border of the uterus. So that is called broad ligament. Again, you can see the broad within the broad ligament is not only covers the uterus, it covers the uterine tube and it also gives a projection towards the ovary, and again it is continued below. So this whole broad ligament has got several parts. The part between the uterine tube and the ligament of the ovary, that is called mesosalpinx. Salpinx means the tube. Okay, the tube. That is called the mesosalpinx. The peritoneal fold, anywhere in the body, we know that is the mesocolon, transverse mesocolon, pelvic mesocolon, the mesentery. So that is the term used, the mesosalpinx. Salpinx means the tube. So just below the tube and up to this ligament of the ovary, this part is called the mesosalpinx. And below it, this area, it is called the mesometrium. Mesometrium. Mesosalpinx, mesometrium. And there is a connection between this fold with the ovary, that is called mesoovarium. Mesoovarium. And also we can see this is continued. This broad ligament, from this broad ligament, then from the ovary up to the lateral pelvic wall, this peritoneal fold is continued and this becomes a ligament like. So that is called infundibulopelvic ligament. From the tube, okay, it is continued to the lateral pelvic wall. That is the infundibulopelvic ligament. through which we can see some arteries are coming. That is the ovarian artery, which is the lateral branch. Ovarian artery is a gonadal artery, which is the lateral branch of the abdominal aorta at the level of L3 vertebra. Okay, this is coming out. So that aorta is there, from the lateral branch, this is coming, and it is coming through this ligament. Okay, that ligament, the peritoneal ligament, the connection between the lateral end of the uterine tube and the lateral pelvic wall. This is called the infundibulopelvic ligament. Okay, so from there, this ovarian artery is coming, and through the broad ligament from below, another artery is coming, that is the uterine artery, which is coming from lateral side. It crosses the ureter and enters within the broad ligament, passes just lateral to the body of the uterus, and ultimately here within the mesosalpinx there is a anastomosis between the uterine artery and the ovarian artery. Okay, so this ovarian artery is entering, and ultimately it will enter within the ovary through the peritoneal fold between the ovary and the broad ligament, that is the mesotherium. This figure shows the tracing of the broad ligament. This is anterior part. Okay, this is anterior part, and it is coming up, and it covers the fallopian tube or uterine tube, and it is the posterior part. And within, just below the fallopian tube, below and in front, we can get this round ligament. Below and behind, we can get the ligament of the ovary. Okay, and this is the anterior surface, and this is the posterior surface of the broad ligament. Okay, and from here, from the posterior surface, there is a connection between the broad ligament and the ovary, which is not seen in this picture. That is called mesotherium, which is not seen. What we can see? We can see the uterine artery. It remains lateral, and it then crosses the ureter. Okay, and ultimately it enters through this lower end of the broad ligament, and ultimately enters within the broad ligament and supplies the uterus and also the part of the fallopian tube. So this is broad ligament, and this is the tracing. Okay, now you may ask one thing, that this is the crossing between the ureter and the uterine artery. Where is the crossing? Where is the exact location of the crossing? Why? Suppose we have to remove this uterus. What we will do? First, we have to ligate this uterine artery. Okay. When we are ligating this uterine artery, we may ligate the ureter also. Yesterday, when I was removing the female composite viscera, that uterus and other structures, you have seen that ureter is coming down and uterine artery is crossing it. So if we clamp it here and ligate it here, what will happen? The ureter, if we ligate the ureter, what will happen? Ureter, what does it contain? Urine. If we block it, what will happen? Is obstructive uropathy. So the kidney will get affected. Then we will have to sacrifice the kidney. If it is detected per-operative time, then there is a solution, because that ureter we can place it directly within the urinary bladder. There is some surgery. But if we can detect, there will be anuria or oliguria. Urine, less amount of urine will pass. The patient will complain, ডাক্তার বাবু আমার তো ইউরিন হচ্ছে না। ও হয়ে যাবে জল খান। Ultimately you do not know whether you have sacrificed already that kidney or not, or one kidney or both kidney, oliguria or anuria. Okay, so the junction is where this junction, this crossing is around 1 inch or 2.5 centimeter away from the cervico-vaginal junction, the junction between the cervix and the vagina. That is called cervico-vaginal junction, from the 1 inch away from the cervico-vaginal junction. Suppose this is uterus, this is the vagina from here. Okay, the cervico-vaginal. So this is uterine artery. Uterine artery is a branch of anterior division of internal iliac artery. Yesterday when I was dissecting, we could have seen that uterine artery. It is coming out from the anterior division of the internal iliac artery. So, in case of PPH, uncontrolled PPH, where there is atonicity of the uterus following delivery, what will happen? There is PPH, that postpartum hemorrhage, and that can affect the patient. There is morbidity and it can cause mortality. The patient may die also. So during that time we have to ligate the anterior division of the internal iliac artery, okay, to save the patient. You can see on either side two uterine artery, and this is the uterus. Okay, this is the endometrium, myometrium. On either side, this artery will form, will give some anterior and posterior branches, and there will be, and this artery is called the arcuate artery, arc-like. Okay, from here we can get some branches, some straight artery, some coiled arteries, and we will learn it. That is the coiled one and straight branch. I think you have already gone through the histology of the uterus. There is a basal zone and functional zone. Okay, the basal zone is supplied by these straight arteries, and the functional zone is supplied by these coiled arteries. Okay, leave it. Now these are the supports of the uterus. One of the important support, that is this muscle, that is the levator ani muscle. It has got several parts. The part in front is the pubococcygeal part, then ischiococcygeal and iliococcygeus, and that is the istiococcygeus, or simply the coccygeus. And behind we are getting the piriformis. So this forms a platform over which the uterus lies. Okay, this is one of the important, and that is the pelvic diaphragm. We know the diaphragm. Here we can get the pelvic diaphragm. Another diaphragm we can get, that urogenital diaphragm in the perineum. Okay, so this is the, and within it we can get hiatus urogenitalis. That means the uro means urethra, then we can get the vagina, and behind we are getting the rectum. So puborectal part and and this forms a sphincter between the urethra and vagina. So it is a sphincter uretrovaginalis. These are the other supports. From behind, this is the symphysis pubis. From the symphysis pubis to the uterus, and from the uterus to the sacrum, we are getting some ligaments. They are nothing, they are the true ligaments. Peritoneal ligaments are the false ligament. They will not give much support to the uterus. But these ligaments from the symphysis pubis up to the uterus, we know that is the pubocervical ligament, and from the uterus to the sacrum, that is the uterosacral ligaments. Pubocervical and uterosacral ligaments. But there is one cardinal ligament, that is very important ligament on lateral side, that you can see. There is transverse cervical ligament on either side, or the Mackenrodt ligament. This ligament is called the transverse cervical or Mackenrodt ligament. In a multiparous uterus, this Mackenrodt ligaments will get affected. We have to tie that Mackenrodt ligament. Otherwise, uterus will come down. Okay, there are several degrees of coming down. That is called a prolapse of the uterus. First degree, second degree, third degree. Even it can come out in obstetric OPD or gynae OPD. You can see the uterus has come out. Okay, because the support is lost. There are several factors. So, one is the most important is the transverse cervical ligament. Another support of the uterus is supported by in front by the urinary bladder, okay, and behind by the rectum, okay. One ligament in front, that is a round ligament. It is pulling the uterus in front. It helps to maintain the antiflexion and antiversion. Okay, so round ligament. So in front, round ligament, behind uterosacral, in front, pubocervical, on either side, that is the transverse cervical or Mackenrodt ligament. So these ligaments are at the level of the cervix. They are the true ligament. False ligament is, that is broad ligament. So this is the transverse cervical ligament or the Mackenrodt ligament. You can see this is the cervix. So all this ligament is attached at the cervix, and you can see the ureter, and there is the crossing of the this uterine artery over the ureter. Always remember, water is below the bridge. Below the bridge we can get the water. So below the bridge means that the crossing. Here we can get the ureter. Okay, at least. So you can see it is around 1 inch away from the cervico-vaginal junction. Okay.